Hi, everybody. Welcome to our November Neonatal Hemodynamics Research Society meeting. We are here for our site presentations, and we're very lucky today to have Dr. Daniel Ibarra-Rios, who is normally our moderator with me, join us as our speaker today. And we also have a wonderful group of panelists, including Dr. Lauren Ruos, who is a neonatologist and associate medical director at the Winnie Palmer Orlando Health Regional Hospital, where she's the director of the neonatal point of care ultrasound program. Her research aims to evaluate the use of emerging non-invasive technologies, including point-of-care ultrasound and echocardiography, for the rapid assessment and management of neonatal hemodynamic disturbances. And we're also happy to welcome Dr. Mahmoud Montasser, who's a consultant neonatologist at the University Hospital Wishaw in the UK, where he's a transport consultant neonatologist at Scott Star Regional Neonatal Transport Team for the west of Scotland, and an honorary clinical senior lecturer at the University of Glasgow. His areas of research are neonatal hemodynamic assessment, cardiopulmonary vascular transition and disease, and functional echocardiography and lung ultrasound as part of point-of-care ultrasonography. And then we're also very happy to welcome Professor Cheryl Rogerson, who's a consultant neonatologist at the Royal Women's Hospital in Melbourne, Australia. She completed a diploma in diagnostic ultrasound and is a board and founding member of the Australian National Ultrasound Certification Program, the certificate in clinical performed neonatal ultrasound. Her research interests are in hemodynamics and lung ultrasound. And so we're very excited to hear Daniel's talk today, which is the value of integrating lung and head ultrasound in hemodynamic consultation. And without further ado, I'll let you take it away, Daniel.
Thank you. Thank you so much for letting me present this approach. I'm really happy to be here with this wonderful panel. So as you know, point of care ultrasound has come a long way since the 50s and 60s, where big machines were not able to go to the patient's bedside. I think all the neonatal made ultrasound was born with cranial ultrasound by neonatologists in Europe and Australasia. And it's important to note that up to the late 70s, echocardiograms were performed by radiologists. In Mexico, I present here in 1982, the year that I was born, one of the first approach to do cranial ultrasound by Dr. Enrique Udaeta and Dr. Mari Segura, which are one of our big teachers in Mexican neonatology. And fun stories as there were low frequency transducer, they used to put saline bags over the baby's heads to get there. And as we know, the adult intensivists are the pioneers in point of care ultrasound. And just to clarify, there's been a lot of controversy regarding especially what's cardiac point of care ultrasound. I agree with what has been published and clarified in the literature that neonatal hemodynamics, and especially when we do a neonatal an hemodynamic consultation, needs to be done by an expert consultant with extensive training, especially to assess PDA, acute pulmonary hypertension, heart function, etc. But also, it's really important to point out that there are some universal skills or some universal competencies that is really useful for all the neonatologists to have. And I think that's the case for lung ultrasound. For lung ultrasound, I don't think that there's an expert model. I think all neonatologists need to learn the whole enchilada. They need to know how to perform it and how to interpret it, because it's a wonderful tool that can help us along the way. And regarding cranial ultrasound, I also think that we can have the concept of a basic universal skill that all the neonatologists should have to identify intraventricular hemorrhage or white matter disease. But there's also a role for the expert consultant, especially with the new high frequency probes for all the neuro-NICU people. So neonatal neurologists or neonatologists that have trained in intensive neonatal care, cranial ultrasound should be one of their main tools, and they should be the ones called like the experts, the expert model. So again, regarding the echocardiography, here we're talking about hemodynamic consultation after extensive training, and also we can discuss what's point of care cardiac ultrasound and how can it help to improve our baby's condition. So as you know, the guidelines have been clearly published. We need about 700 echoes with supervision, and we need to do it in close collaboration with cardiology. But it's really interesting how in pediatric research over the last year, ultrasound made by neonatologists had been groups of interest, and it has been published by echocardiography performed, neonatologists perform echocardiography, but also lung ultrasound and also cranial ultrasound. So these series reflect the interest and the expertise that has been developing with the ultrasonographic technique. So I have the great fortune to train with this dream team with Patrick, Amish, Danny, Regan, back in Toronto in 2016, where I did the extensive training in echocardiography. And when I came back to Mexico, I had a pretty decent ultrasound machine, but I didn't have any fancy advanced echocardiographic tools. But I remember I had a beautiful hockey stick that back then no one used it, and I was really interested in how can I use this to get more information from my baby. So right now in Mexico, I have the fortune to train 4 neonatologists with the expert model. Here's Doctora Becerra, which is the head of the Echo Lab at Hospital Infantil de Mexico, and also Caro Michel just finished her fellowship in Montreal. But so there's 6 of us, but we're all concentrated in the center of the country. So we need more people who have the extensive training in echocardiography. And then in 2017, the Mexican Federation of Neonatology brought Daniel De Luca and Nadia Youssef to do their famous workshop on lung ultrasound. They did it in 3 states of the Republic, and some of us had the fortune to take it, and we were really immediately mesmerized by the lung ultrasound technique. And then we had the fortune to do this little book with my friend, Dr. Ale Sanchez. Ale is so enthusiastic about lung ultrasound that she bought her own equipment in order to do ultrasounds in her perinatal hospital. And we did this book. It's in Spanish, but it has all the basic stuff around lung ultrasound after we had a couple of years training in the technique. And now we have a group of people in Mexico City where we're trying to do our guidelines as we're spreading the technique around the country, and there's a lot of interest. We want to do it in a standardized fashion. So we're in the process of writing the guidelines, and I'm really glad that Mahmoud is here because one of the papers we reviewed is here. And I cannot stop to mention my friend Yasser El Sayed and all the Focus Neo group for all the resources that are available for us to learn in point of care ultrasound. And just some concepts, I think you all know it. When we do the lung ultrasound, we normally look for the bad sign. That's the view between 2 ribs to find the intercostal space. And then we will look an hyperechogenic line that has a to and fro motion, which is a pleural line. So a normal lung has pleural sliding or lung sliding, and we will see the reflection of the pleural line, which are the A lines. So a perfectly aerated lung, which is never the case in a baby in the NICU, it's an A pattern with lung sliding. So the A lines is the reflection of the pleural line that goes to infinity if the sound doesn't come with anything but air. But if we have an liquid air interface, we will have the ring down effect, where the emitted waves from the resonant vibrations within a bubble tetrahedral complex will create a linear artifact in the axis of the insonated ultrasound wave that starts from the point of origin and ring down to the end of the screen without fading. And these are the B lines, which is a specific term for the ring down artifact. And in order to call it a B line, it needs to originate from the pleural line. It has a strong light rate appearance, obliterating other background, and it can erase the A lines, and it moves along with long sliding. So here we can see the different intercostal spaces. We can see the pleural line, the to and fro motion, and we can see the B lines. And some of these B lines are coalescent and gives us a wide long appearance. And when we have a consolidation, we stop seeing the artifacts, and now we are seeing the actual lung, because it's been either infiltrated or it's collapsed. So here we are seeing the lung, and when we are looking at the A and B lines, those are artifacts. So in a well aerated lung, we will see artifacts, and when we have the most severe disease, when there's less aeration, we can see the hepatized lung. Here you can see the liver, the diaphragm, and the lung. And consolidations can be classified as small or extensive. Arbitrarily, normally we use the 5 millimeter cutoff, but it can vary between the different groups. And here are the regions that we normally explore. From the parasternal line to the anterior axillary line, we will have the anterior region, and we will separate superior and inferior by the intermammillary line. We will have the lateral area between the anterior axillary and the posterior axillary line. And we can explore also the posterior regions between the paravertebral lines and the posterior axillary line. And the B lines have been validated in animal models. So the way to know in an autopsy the exact amount of water in the lung is this technique called gravimetry. So here with a piglet model, they did an oleic acid model of lung damage, and they counted the B lines. They did the gravimetry, and look how it correlates really well, the number of B lines with the amount of actual water in the lung. And then the concept of a semi-quantitative scale. A semi-quantitative scale is to put a number on what we're seeing. So a perfectly aerated lung is a 0. When we have an interstitial B line pattern, that means that we have more than 3 B lines. It gives us 1 point. When these B lines became coalescent and we have a wide lung appearance, it gives us 2 points. And when we have consolidations, it would be 3 points. And the regions that normally are explored are the anterior, superior and inferior, and the lateral, where normally the babies are in a supine position. And this semi-quantitative score or lung ultrasound scale have correlated well with CT scan findings. It correlates with the Silverman-Anderson. When you have a bigger amount of labored breathing, you will have a higher score. It correlates with oxygenation. The worse you oxygenate, you will have a higher score. And it also, in animal and human models, it correlates with inflammation. When you have more inflammatory markers, you will have a higher semi-quantitative scale. And identify the lung sliding is really important, because when you don't have lung sliding and you have only a pattern, you will be in front of a pneumothorax. So here you can see a pneumothorax where you lose the lung sliding. When you have lung sliding and you do an M mode, you will have the seashore sign, because the area that is moving becomes like wavy and gives you this sandy appearance. And when you have a pneumothorax, you will have the barcode sign, where there's no lung sliding. So you will have the barcode sign. In English, I think it's also called the stratosphere sign. So absent pleural sliding, only A lines, and no lung pulse. And also, traditionally, ultrasound has been used to identify fluid. This is a baby that had a diaphragmatic hernia that was transferred to third level care after surgery because they couldn't extubate the baby. And as you can see, we have a refrigerant pleural effusion where you have the 4 wall signs. And if you do an M mode, you will have the sinusoidal sign. And why? And it's been demonstrated that you can learn lung ultrasound in a workshop with limited hours of talks and reviewing material, and then you need about 20 to 25 supervised scans to become proficient in. And then regarding head scans, I think all of us went through Nick's practical head ultrasound for neonatologists when we were training. In a lot of countries, head scans are driven by neonatologists. And when we're doing our hemodynamic consultation, we always go by our MCA and sometimes the anterior cerebral artery. So it's a region that we normally explore. In Mexico, we've been trying to standardize our terminology, and we've been using a lot of the Canadian consensus for the classification of preterm brain injury. And we have also a great relationship with Khorshid. A lot of times we have bothered him with our cases by WhatsApp. And when we do an hemodynamic consultation, I'm really fond of this this document, because it was Regan's sheet where we would collect all our measurements after we do the scan. Normally, when we do an hemodynamic consultation, first it has a lot of clinical stuff. So we review the baby history. We do we explore the baby. We collect all the data regarding X-ray, blood gases, and then we do the echocardiography. And after we do echocardiography, first we take all the images and then we measure. So I've been using this since I came back from Toronto to collect the data and to integrate my consults. So when we started, we were doing just echocardiographic assessment, and you can see as a normal hemodynamic consultation service, our main issue was acute pulmonary hypertension in a tertiary level referral center, then PDA, then shock, and then chronic pulmonary hypertension, our BPD babies. So generally, globally, we recommend a change in management in 45% of cases. And also really important, in 19% of the studies, we would find incidental findings, including misplaced catheters, thrombus, and congenital heart disease. But then this is from 2019 to 2021, 484 hemodynamic consultations in 209 patients, where we integrated head and lung ultrasound in every one of them. So globally, in all the consultations, 67% had an abnormal lung ultrasound. And as you can see in patent ductus arteriosus, a small amount of them were normal, but we also have a really early assessment, babies with RDS. And then we have all the babies with an interstitial pattern. It's really difficult to integrate between interstitial pneumonic and interstitial cardiogenic. Interstitial pneumonic would be the classic parenchymal affliction, when you have some spared areas and some areas with more B-line, and a pattern with an interstitial cardiogenic pattern is a more homogeneous pattern. We also had BPD babies with that went to surgical treatments, and also a lot of time where you're assessing a PDA, you can be dealing also with other problems like pneumonia, atelectasis, etc. As you can see, we normally recommended medical treatment in 23% of cases, and surgical treatment only in 6.9%. And we normally go by an expectant management if the ductus is not a problem. And 84% of our babies have an abnormal lung ultrasound. So if you're assessing a PDA, you will find something in the lung. The only problem that I've found with the scale or the semi-quantitative scale that we use, if we use the classic semi-quantitative scale, when you're assessing lung fluid, and you have an interstitial pattern, it will be 1 in each area. So if you have a generalized interstitial B-line pattern, you will normally have 6 points. So that's a problem when you're trying to assess increased pulmonary blood flow. So some adaptation for the normal semi-quantitative scale have been proposed. I like this one called Lucas, where, as you can see, they are all interstitial patterns that go all the way up to a wide lung. So this is an area of research that is interesting, especially when we're assessing increased pulmonary blood flow. What would be the ideal scale to use? There's been some descriptions of the use of lung ultrasound in PDA. First, a poster presentation at PAS in 2019, where they did the classic semi-quantitative scale, and a cutoff of 10 gave a sensitivity of 83 and a specificity of 61 to predict ductal constriction after PDA treatment. Then there's this big study by Sao and colleagues. They studied 221 low birth weight infants, and they performed lung ultrasound on the 4th postnatal day, and they showed a statistically significant difference with the babies with a PDA, 8.8 versus 6.7, but it was weakly negatively correlated with gestational age and positively correlated with PDA diameter, and they found with a cutoff of 9.5, a weak diagnostic test to predict that the PDA was open. And the area under the curve was low, 0.6. And then Yu and colleagues did sort of the same approach. They studied 158 babies, and again, on the 4th postnatal day, they did the lung ultrasound, and the diagnostic performance improved with an area under the curve of 0.7. With a cutoff value of more than 9, with a sensitivity of 93 and a specificity of 50. And again, here they found that the lung ultrasound scale was positively correlated with the ductal diameter, and also with the LAAO ratio. This study is really interesting by Silvia Martini. They use daily lung ultrasound, and by transthoracic electrical bioimpedance, they measured the total thoracic fluid content and also echocardiography. And they found there was a correlation between lung ultrasound and the total thoracic fluid content and the presence of a PDA. So this gives us a biological base that babies with PDA have a more B lines, and by electrical bioimpedance, they have more water content in the thorax. Then Song and colleagues did this study with 81 infants, less than 25 weeks of gestation, and they used more extensive scales, again, to try to improve the performance of it. So they also used 12 areas instead of 6, and a score of 0 to 4 to predict the babies that were going to be ligated. So a cutoff of 36 with this scale on the 14th day of life had a sensitivity and specificity of 96 and 86% to predict the babies that were going to surgical ligation of the PDA. And finally, this study by Marilena Saboya that demonstrated in 5 infants that underwent surgical ligation that the lung ultrasound score went along with the left ventricular output. So that reflects that the reduction in pulmonary blood flow and interstitial edema after surgical ligation. And with our cases, we had one thesis from Mariela. This was her thesis from pediatrics. 36 patients in 2019, 13 received pharmacological treatment. And when we did the lung ultrasound, here we used a different scale. We classified the lung edema in mild, where there was more than 75 respected areas, moderate when there was 50% respected areas, severe when there was only 25 respected areas, and wide lung as critical. And we have the before and after assessment of the lung ultrasound, and it becomes better after pharmacological treatment with less severe edema and wide lung and more mild edema cases. And this case is interesting just to reflect the usefulness of lung ultrasound. We were consulted by a baby that received 2 prior doses of pharmacological treatment for the PDA, and they had this X-ray and they thought the PDA was still a problem. And as you can see, it was a restrictive PDA. And when we explored the lung, we found a lot of consolidation and this complex effusion. After we finished the ultrasound, we did the procedure guided by ultrasound, and we obtained fluid. That's one of the other main advantages of lung ultrasound, that it makes your procedures more safe. And within some hours, we knew that there were some cocci there, and we could quickly diagnose Staph aureus MPM. And in the hemodynamic assessment, we had mid-cavity flow acceleration and a hyperdynamic pattern of a baby that was septic. Regarding systemic hemodynamic instability, as you can see, we had some normal cases, but a lot of them had lung involvement, including pneumonia and atelectasis. 73% of babies with systemic hemodynamic instability had an abnormal lung ultrasound. And here I'm going to present some special interest population that we have found. Regarding hypernatremic dehydration, it's common in third level care referral hospital. We receive babies with hypernatremic dehydration, and a lot of them are bradycardic. So when they are bradycardic, they called us. So we reviewed 12 cases of hypernatremic dehydration. They had a baseline sodium of 167, going from 148 to 191. And heart rate was around 100. The interesting thing is that no patient was hypotensive on admission. However, 50% of them received fluid boluses, and the main reason was the bradycardia. As you can see, sodium didn't correlate either with heart rate, systolic blood pressure, or lactate. And we found a pretty constant hemodynamic pattern where systolic function was normal. There was some abnormalities in diastolic function and some cerebral edema. We found incidental findings: 1 thrombosis, 2 misplaced catheter, a natural septal defect, and a small ventricular septal defect. 4 babies had cerebral edema, and all of them have a normal. And this is a really interesting case, a perinatal case. So this is a placental chorioangioma diagnosed prenatally. The baby was being assessed by Dr. Alfonso Martinez, which is our fetal cardiologist. And at 34 weeks of gestation, we have a combined fetal ventricular output of 860 milliliters per kilo per minute. So a cesarean section was planned. The problem with this chorioangioma is that it works as an arteriovenous malformation. It gives the fetus a high output congestive heart failure state, where the left to right shunt as a result of intratumoral arteriovenous shunting and chronic fetal hypoxia secondary to insufficient placental function or anemia. So we have an enlarged right heart with increased vascular reactivity, anemia because of fetal-maternal hemorrhage or blood sequestration, and polydramnios with increased urine production associated with fetal hyperdynamic circulation. So here's a big risk to change this baby from a high cardiac output state to a low cardiac output state. So resuscitation with an intact cord was prescribed by our fetal cardiologist. So it was around 3 minutes of open cord with some CPAP via a T-piece. And after the baby was born, you can see it has a specific pattern with dilated SVC and IVC, increased right heart dimensions, and also increased pulmonary venous return. You can see here how the lung ultrasound helps us to know how well our CPAP support is functioning. And you can see how we follow this baby's output. When the baby was born, it had 236 LVO and 299 RVO. And we followed the baby, and at 1 week, we also found a small interatrial communication. And at 1 week of age, we had a high RVO with a 2:1 QPQS. We start some diuretic, and with that, we could stop oxygen, and the baby was discharged. And also the baby had a tendency of cerebral vasodilatation that it became better after the baby, after we stabilized the baby, first preventing a low output state and then with some diuretic. Regarding acute pulmonary hypertension from 2019 to 2021, there were 97 consultations. And as you can see, a lot of the time we have parenchymal involvement. We had a lot of pneumonias, atelectasis, pleural effusion, pneumothorax, and all the lung malformations we received. So 96% of the times we had an abnormal lung ultrasound. And with the recent pandemic, we have worked a lot with respiratory virus. So first we had these 32 COVID babies, where we found this pattern of COVID pneumonia with B-line interstitial pattern, wide lung, and different degrees of lung consolidation. And as you can see, we did the lung ultrasound, the hemodynamic consultation, and the head ultrasound. And the thing with viral pneumonias is that the lung ultrasound is really useful to know the severity of the pneumonia and the extent of the involvement, but it's not good to differentiate between different viruses. Here you can see the whole spectrum with interstitial line V pattern, consolidation, pleural line abnormalities. This one is a COVID baby. This one is respiratory syncytial virus, parainfluenza, and influenza. So in the program in the tertiary level care hospital, we review 47 patients with viral pneumonia. 35 SARS-CoV-2, 4 rhinovirus, 4 RSV, 3 influenza, and 1 parainfluenza. And as you can see, the pattern found in lung ultrasound was an homogenic interstitial B-line pattern in 94%, pleural line abnormalities in 85%, coalescing B-line, wide lung in 60%, and consolidation in half of them, 51%. Most of them were posterior. 30% of these babies had pulmonary hypertension on echocardiographic evaluation, and only 2 of them had biventricular dysfunction. And when we are doing the lung ultrasound, a lot of the times we find the thymus there, and we see the thymus in our X-ray. So an enlarged thymus was found in 11 patients. And as you can see, when we do our lung ultrasound score, with more respiratory support, you will have a higher score. And also the babies that survived had lower scores and low FiO2 needed. And here you can see the correlation between the lung semi-quantitative scale and our FiO2. When you have a higher FiO2 need, you will most definitely have a high lung ultrasound scale. And here's one example of our babies with an enlarged thymus noted on radiography, and then we measure them by ultrasound, finding bigger than what's been described. And when we correlate when we see the association between our ultrasonic findings and mortality, pulmonary hypertension increased mortality and also the presence of consolidations. And the babies that had an enlarged thymus, it appears that it was a protective factor. Other population that helps a lot to do the whole assessment is congenital diaphragmatic hernia. We've been working a lot with the different phenotypes, cardiac phenotypes of diaphragmatic hernias, and we have discussed this in different sessions. So we will have the first hemodynamic phenotype with mild pulmonary hypertension without ventricular dysfunction. We would have the pre-capillary pulmonary hypertension phenotype, like the classic pulmonary hypertension picture, but also we have the moderate to severe pulmonary hypertension with left or biventricular dysfunction that we call the post-capillary pulmonary hypertension phenotype. And regarding the different phenotypes is what we normally use for management. Normally, the first phenotype needs sometimes they need a little bit of milrinone, but normally they don't need most intervention, and they are under surgical condition after adequate ventilation. Then the second phenotype, in this phenotype, we normally use milrinone, and if it's needed, we can use a little bit of nitric after the first days. But the most difficult one is the third phenotype, where you need to be careful with nitric, and a lot of times you need to give support to the left ventricle, and even using prostaglandins to open the duct. So we have 24 survivors, 2 died without surgery and 2 died after surgery. And when we see the predictors of mortality, a high CO2 is a predictor that has been described widely in the literature, but also the babies that died had lower left ventricular output and increased pulmonary vascular resistance reflected by RV-TPA-T ratio or pulmonary vascular resistance index. And when we analyze the babies with the baseline echo, the pre and post-surgical one, you can see that it has a tendency of increasing both right and left ventricular output. And then we have a lowering of the pulmonary vascular resistance. And when we look at the MCA, babies normally have a tendency to have a vasodilatory compensation. And also when you see the survival probability, the higher mortality is the precapillary phenotype. And when we look at the lung in diaphragmatic hernia, it has been described in this paper from Dr. Yuri Corsini, the partial absence of the hyperechogenic line representing the normal diaphragmatic profile, absence of the pleural line in the affected hemithorax, absence of A lines in the affected area, multi-layered area with hyperechogenic contents in motion, that is the gut, and the presence of parenchymatous organs. So normally what we do is we review these scans with our surgeons, and it has been described also in the literature that these scans can help to plan the surgical repair. This is the latest diaphragmatic hernia. When we did the first assessment, we found the baby on supraventricular tachycardia. The baby got sick in the night, and they used a lot of drugs with arrhythmogenic potential, so we weaned a lot of them. Finally, the baby got with a little bit of milrinone only, and we pulled out the catheter that was deep. Sometimes with diaphragmatic hernias, with the traditional X-ray, you cannot tell that. And you can see here the bowel on the left side, and we didn't find any parenchymatous-like organs in there. So one parenthesis regarding catheter safety. Also, we normally in our hemodynamic consultation look at the lines. We normally find it as an incidental finding at a misplaced catheter in 30% of the consults. And for sometimes we were polishing catheters. So the fellow would, in the handout, would say, I put this PICC line, and by the traditional method, which is measuring and then several X-rays, it's well placed. And we found that 40% of them were misplaced when we reviewed them by ultrasound. Then with the same baby of the diaphragmatic hernia, after surgery was pretty stable, and 1 week later, the baby presented fever. So we evaluated the baby, had a little bit of hyperdynamic circulation, and small pleural effusion in the site of the surgery, which is a common finding. And another parenthesis regarding procedures. Again, with ultrasound, we can mark the safe area to do the lumbar puncture, and that can help us to have less traumatic events. So we did this study where we compared 12 assessments, where we did, from these 12 assessments, we did 11 procedures, because in one of them, we didn't find enough fluid to do it. So we compared 11 procedures guided by ultrasound versus 82 controls. And we found 9 versus 26 macroscopic traumatic pleural taps. And then also microscopic, we have found a significant difference. So when you guide your procedure, especially lumbar puncture, it's really useful. And you do it with the same probe. And 3 days later, we assessed the same baby. And as you can see, the pleural effusion got bigger. The hemodynamic pattern was the same. Some hyperdynamic circulation, nothing more, but now you can see that you have a big pleural effusion and consolidation. And at the same time, we obtain a positive blood culture. And finally, one of our main areas of interest are our BPD babies, or chronic pulmonary hypertension babies. So we use Amish, Jane, and Mount Sinai's approach, where when we have 36 weeks corrected age, we do an echo on these babies. So this was from January 2018 to December 2021, 72 babies that were scanned doing lung and echocardiography. From these 72 babies, 41 had only parenchymal disease. And 22 of them have chronic pulmonary hypertension, and 9 of them had a left to right shunt that was becoming important. And we found consolidations in 21 of these babies. From these 21 consolidations, 12 of them after assessment were considered to be infectious. And as you can see, the babies that have chronic lung disease and pulmonary hypertension have worse outcomes. And we normally treat as a first line these babies with diuretics. So we did the before and after diuretic assessment. And as you can see, when we graded the edema, again, here we did mild, moderate, and severe, depending on the respected areas. After diuretic, we had an improvement, having an increase in mild edema and a decrease in moderate to severe edema. And in 59% of the babies, we acquire a step down in respiratory management. And when we did the before and after echo, we look at the decrease in the right ventricular output and also a decrease in pulmonary vascular resistance. And finally, regarding head ultrasound, these are the from 2019 to 2021, from the 484 consults, 30% of them had an abnormal head ultrasound in consult. And as you can see, PDA is related with a lot of intraventricular hemorrhage. And again, sometimes when we have systemic hemodynamic instability, it has to do with babies that has post-hemorrhagic dilatation. And when we deal with the chronic babies, we will see more white matter, white substance disease. And there are some beautiful cases like this one. This was a baby that came from Oaxaca. It was referred to tertiary level care because of intractable refractory seizures. And we assessed the baby because it was hypotensive from all the medication. And as you can see, immediately we found some rhabdomyoma and some tumors in the head scan. So a tuberous sclerosis diagnosis was made at the bedside. And another example, a 40-weeker female newborn product of the third pregnancy. It had a normal fetal middle cerebral artery Doppler. It was born by emergency cesarean section due to meconium stained fluid and lack of progression of labor. It received extensive resuscitation and developed bilateral pneumothorax. Then the baby was transferred to a tertiary level care, where we found pulmonary hypertension and the persistence of the pneumothorax. So we managed this baby with a little bit of milrinone, and we assessed the baby on the first day of admission and at the next day. Upon admission, we had the normal MCA from the fetal studies from the mother. On our first assessment, we had a lot of trouble to get the MCA, and at the second day, we found some cerebral vasodilation. And at 10 days of age, we didn't hear back from the baby. They didn't consult us back. So we went to see what happened. And when we did the assessment, we found this big MCA, stroke. And then a comprehensive approach was carried out. And then here comes all the expert imaging techniques. But the interesting thing of this case is that we diagnosed the baby without any neurological symptomatology. At the moment, the baby starts with these seizures up to 6 months of age. And finally, I want to present you our crashing baby algorithm. So we integrated the algorithms that were in the literature. It's basically Nadia Youssef safe approach. Sorry that I'm gonna skip these ones to go to the discussion with the panel. And this is our algorithm for a neonate with acute deterioration. We classify this baby in cardiac arrest or hemodynamic instability or exclusive respiratory symptoms. We can use the lung ultrasound, where first we can verify intubation, and then we help as a team with all the elements that can be missed when you're assessing a baby that is crashing. So we're an ultrasound team, but we also help checking the oxygen, checking the point of care blood gas analysis, and then doing the imaging. So if the baby is in cardiac arrest, we ensure the baby is adequately intubated, and then we can use ultrasound to check heart rate and contractility, rule out asystole or pulseless electrical activity, And then if the heart rate keeps below 60, we go to rule out a tamponade. Then if we have a baby with hemodynamic instability, normally what we teach as point of care echocardiography is a subcostal long axis and a 4-chamber view. And there we can do maybe MAPC, TAPC, and so we can characterize the baby with a contractility problem or a left or right ventricular outflow tract obstruction, and an urgent consultation to cardiology or hemodynamic assessment needs to be carried out. And if the baby has exclusive respiratory symptoms, we go immediately to see pleural sliding to diagnose a pneumothorax, or if there's a pleural effusion that needs draining. And with this, I will finish my presentation to go for the discussion.
Thank you so much, Daniel. That was really amazing. What an overview and diverse patient experience that you've had there. I wanted to, I'm going to ask you a question of my own before I get to the others, if that's okay. Could you expand for us a little bit on how you integrate ventilator management with lung ultrasound, and you know, can you give us some examples of how you've been able to change ventilator management? Is it something that you do often? You know, can you tell us a little bit more about that?
Yeah. So one thing I encountered was that it's more difficult to give a ventilatory suggestion than an hemodynamic one. So as we're a T&E people, we normally go to the hemodynamic assessment, and people don't get as offended with our suggestions as when it's with ventilatory management. But that changes when everyone knows how to do lung ultrasound. So when you become familiar with lung ultrasound, one of the most attractive things is pulmonary recruitment. So when you recruit a baby, you normally go from a consolidation to a B-line pattern, or to or from a wide lung to a B-line pattern. You never try to go to a completely A-line pattern because that's risky, and you cannot assess over distension with lung ultrasound. So the approach that we normally do is, when we do these maneuvers, we also look at the right ventricular output, especially. So you can do your recruitment maneuvers. You can see how the lung gets better, but again, from a wide lung to a B-line pattern, or you broke an atelectasis and you go from consolidation to a B-line pattern. And what we've done to assess that we're not overventilating, it's right ventricular output. And when we're recruiting, you normally also use X-ray. It's one of the scenarios where you cannot rely only on lung ultrasound. But if you, for any reason, leak, like pneumothorax, the lung ultrasound is one of the most sensitive things to diagnose it.
Daniel, so Daniel, that was a great talk, as always, to see how many different ways that we can use these modalities, and the experience that you guys have and what you've been able to build in Mexico is pretty expansive and impressive. Talking about mechanics and the vent, and then tying in together some things that are coming out of the adult literature with what anesthesia is doing to try to find out about optimal PEEP. And then you go into adult cardiology literature, and they're using lung ultrasound with echo to try to assess diuretics, assess congestive heart failure, and all of these things as an outpatient. Have you been able to explore much of that finding of optimal PEEP, especially in the super tiny baby, or post-op anesthesia, or are you ready to extubate or not? All of those questions that I feel like the adults are ahead of us, yet the lung ultrasound in them is so much more challenging than our somewhat translucent humans. And so I just love your thoughts on if you guys have explored that yet.
Yeah, I don't have extensive experience on that. I would normally do that in my own patients, because a lot of times I was a consultant, and when it's in my patients, I feel more confident to do it. I think it's worthwhile to explore different echocardiographic measurements, also diastolic function. It can be really useful. And right now I'm working in one of the main perinatal centers in Mexico. So I'm really excited because I think that's precisely one of the most exciting areas of research, like how to find optimal PEEP, recruit a baby, and all mix long ultrasound with echocardiographic measurements. I don't know if anyone else has some experience in this.
Yeah, thanks, Daniel. I mean, your talk is phenomenal, and your program is amazing. I mean, just to answer this particular question that Tina asked about guiding recruitment for ventilated babies, it's quite fascinating to use this bedside tool. Actually, I use it all the time when I'm attending for my babies. And as you said, it's difficult to try to diagnose hyperexpansion, particularly, you know, babies who are on oscillator, for example. But it gives you an idea. For example, if you have a small baby, a preterm baby with RDS, when you do the lung ultrasound and you see like mainly A profile, you know it's quite hyperexpanded. Then you come down on your PEEP a little bit. So I don't know if you use it in that kind of fashion or not.
I've used it some in conjunction with echo, or I just happened to be doing a hemodynamics consult, and I haven't merged the two, lung and echo, together yet in my consulting. But the tiny baby team, I can look at the IVC will be really big and a tiny baby, and it doesn't look like there's good pulmonary blood flow, and the LV looks underfilled, and then the RVO is a little bit low. And so I talked to them like that, those things don't go together. And is there any chance your mean airway pressure is too high? And they've gone down on PEEP, and then I come back and assess and say, oh, yay, that's what we saw. But I haven't gone to that finesse yet that it sounds like some of the other patient populations are doing, where they just routinely do this together and are doing markers. And I feel like in our tiniest babies, we really have the opportunity to spearhead this research.
There's a couple of case series where they describe how they do it, but yeah, I think it's a really exciting scenario there.
Yeah, I think those are really great points. Cheryl, I just wanted to bring you into the conversation. And
so there was a couple of things I was going to add. I think that, most of this, it's really important that it's always validated with long-term outcomes, because we have lots of anecdotal things that we do, and we know they've worked on one, but they really need to be validated that it's actually changing the long-term outcome of our infants. And Arun Set from Australia has done some really good work on planning for extubation. It should be due to be coming out published soon. Sort of, lung ultrasound, and can you predict which infants will be successful at being extubated, and obviously then going on to say, can we extubate them earlier than the clinician would expect? So that should be coming out fairly soon. But I also think that something that we do need to do is validate all of these changes, all these things that we're doing with, are we actually making a difference? Obviously short-term differences are important, but also long-term outcome as well, which is sort of what we're missing a bit in the hemodynamic field at the moment. We're really focusing on short-term changes. Yeah, that was one of the things I was going to say. Any questions?
I was just going to highlight that the late Dr. Gissinger was able to publish before her passing. I don't know if you guys were able to see that work about the decrease in the IVH mortality with implementation of the hemodynamics program. That said, there's lots of confounders with that and what all else was being done at the same time. But that's really I feel like our first piece that I've seen of showing it may not be a true long-term outcome, but a meaningful short-term one that has really good long-term implications.
Thank you for that. Just switching gears a little bit, we had some questions in the Q&A. Kurt Duvall from Australia was asking about the accuracy in diagnosing PDA and extravascular lung water, and whether it would be possible to apply pixel grayscale software to lung ultrasound images. Any thoughts about that?
Yeah, Dr. Francesco Raimondi has a paper on that. And yeah, that would be an endpoint where you can do a grayscale analysis with our normal semi-quantitative approach. In adult medicine, there's automatic beeline count by some equipment. In babies, it just doesn't work. I've tried it, and it's not a useful tool. But the grayscale analysis, sort of what you do with for predict what maternal fetal doctors do with how this is called to predict lung maturity. I forgot, but it's a grayscale analysis. Yeah, that would be an interesting thing to look at. So more automatization with the improvement of of equipments. And yeah, the thing that I found problematic with the scale is that you will have a beeline pattern. So you only have 1 point for a beeline pattern. It doesn't matter if you have a lot of beelines or less beelines, as long as you don't have a wide lung appearance. So different scales that can expand the numbers between the amount of beelines would be I think would be helpful. But again, it has been discussed that maybe as it's a multifactorial disease. For example, when you have a PDA, you don't only have the PDA, you have a lot of other things going on. We might not get there until we have some more sophisticated approach, like Dr. DeWalt said, like grayscale analysis. And I totally agree with that. We need to take into account different hemodynamic parameters. The thing with what it's in the literature, they only take the ductal diameter and LAO ratio. Dr. Marilena Saboya, it's more extensive, but it's 5 kids that went under surgical ligation. But I think we're in this state of describing cases, describing populations. Once it becomes like a routine thing, where also when we do the PDA assessment with normally the AFIFS and Patrick scale for grading the PDA severity, we can also do a semi-quantitative scale. It's just I don't know what scale to use. I don't know, Mahmoud, if you've done something different.
We essentially use the guidance of, because the beelines are a reflection of the amount of interstitial or alveolar fluid inside the lungs, right? So if you have few beelines, that means the lungs is not congested. In case there is a PDA or anything else like chronic lung disease, for example, that means the lungs are adequately recruited, not much interstitial fluid. Whereas the more beelines you get, that means the more interstitial fluid. And then you can actually monitor the non-invasive support, for example. You can increase the PEEP or reduce the PEEP accordingly. Or you can monitor your diuretic therapy, for example, if you want to give diuretics for chronic lung disease, or if there is a significant PDA that you want to offload the lungs with the fluids. So this is what we usually use. It doesn't matter the score, but you just get serial scans and see the response of whatever management you do.
I think, Daniel, you really hit the nail on the head with the problem with the 0, 1, 2, and then 3 for consolidation score, which has been extensively used. 1 is very, very broad. You've got, from 3 B lines to maybe 20 B lines, but not quite a whiteout. And they can't be the same sort of lung. And I think somehow we need to differentiate what is traditionally being called a type 1 lung, like more than 3 B lines, but not a whiteout, because that's sort of the area that we're really trying to change. And I think you can either do it serially, like Mahmood suggested, where you just follow your own patient and see the B lines go down and presume that it's related to the therapy that you've done, or we come up with a grayscale. And there is a grayscale that has been used in PhD studies, but unfortunately, they didn't actually correlate well with the 0, 1, 2, 3 scale. So I'm not quite sure that there's a JPEG or a scale at the moment that's suitable for neonatal lungs. It has been tried in a couple of studies.
However, if I may add, in terms of the scoring system in the management of respiratory distress syndrome, like the RDS and surfactant deficiency, it's already validated, and lots of publication out there, from the Professor Raimondi and other colleagues as well. So, but probably later on during the neonatal period, that's a controversy is becoming more kind of prominent.
Can any of you comment a little bit on the differentiation of the different diseases? Is there a way with ultrasound that we're able to differentiate the causes of B lines, or are we just looking at the clinical picture? Can you talk about that a little bit more?
I think Adel made a good point in the Q&A. I remember Adel Mohammed, when I was training in Toronto, he was doing the first lung ultrasound there. So yeah, as he said, no, you have to differentiate between a B-line pattern that is cardiogenic from pneumogenic, and that's really difficult because you will normally have the pneumogenic disease present. But when you found extensive consolidation, small and extensive consolidation or collapse, you need to think if is this a PDA or is this just bad chronic lung disease that is developing, and the morphology helps a lot. So you can see the pleural line thickness. You can actually measure the pleural line thickness. You can look for a collapsed bronchogram and a small consolidation that goes more with a kind of a chronic pulmonary lung disease going on, versus a B-line pattern that something that is really important that responds to either pharmacological treatment or diuretics.
Yeah, that's right, Daniel. And usually cardiogenic or PDA related, because we're talking about neonates, PDA related, pulmonary edema, if you like. The pattern of B lines is very, very homogeneous, as if it's just giving you white lung. The pleural line is usually hazy, but not completely disintegrated, not much consolidation collapse. So you'll see it's just a homogeneous pattern of B lines all over.
Yeah, I was gonna echo that. I've seen some babies post PDA coiling that had that classic pulmonary edema and their LV output was low. And, we've started now doing milrinone in some of those children, and then also had a baby who we assumed that's what it was, but when we actually did the lung ultrasound, there was just a lot more consolidation versus atelectasis than what we typically see with the classic B lines. And ended up working that kid up for an infection. The only thing that I've really been able to discern the difference in is looking at things like meconium aspiration has a pretty classic appearance, and then great for trainees and how it changes over the course of the days. And then pulmonary hemorrhage, I've had a pretty good experience with that one. But in terms of just B lines, I think you've got that classic pulmonary edema look. And then, but if you've got a BPD baby or a baby that may have changed ventilatory status, it's going to be very confusing.
Thank you for that. And thank you for mentioning the trainees. I wanted to get you guys to each maybe comment on words of wisdom, you know, bit of advice. We have a lot of, you know, young people on the call. You know, what do you think are important factors that they consider as they think about getting into this field and maybe starting programs of their own?
I would say, first of all, do the things that you normally do exactly as you normally do it. And you can start using lung ultrasound. And then once you're confident, because at the beginning, it's really important to correlate what you're finding in your lung ultrasound with what you're seeing in your traditional X-ray. If for some reason the baby has a CT scan or is going for a lung CT, go and scan that baby and then look at the CT scan. And if for some unfortunate reason the baby passed, go to see the autopsy. So because that's when I consider especially lung ultrasound as an extension of normal when you explore a baby. So it's the fifth pillar of insonation. So you need to go step by step, and once you have enough confidence with lung ultrasound, you can stop taking X-ray, because one of the main things you want to do is radiate the babies less. But when you're starting, do the things the same way you normally do, and normally have a mentor. So it's been pointed out in the literature that you need around 25 supervised studies to start going on your own.
Yeah, I'm gonna echo that. It's a learning curve, and we all started like scanning normal babies, and then you just bit by bit you just expand your experience. And as Daniel said, don't make decisions just based on lung ultrasound initial steps. Look at your X-ray as well. Look at the baby. Look at clinical picture, and just it's a learning curve.
Yeah, I mean, I'd echo the same thing. As everyone knows, we have a pretty extensive training program in Australia, and generally the most important thing to identify first is a good supervisor, a supervisor that will be able to be there and help you get through some of those initial technical things, like, you know, what probe to use, how much gel, what settings to use, how many focal zones, what your dynamic range should be, whether you should have the speckle reduction off or on, how best to get the images. I mean, I know most of them have a lung preset, but often that lung preset is more for bigger children, not the very tiny neonates. Sometimes you have to set your own preset. So it's just really good to have a supervisor who can do all of that with you. And I think, yes, as you said, you know, you at least need 25 before you probably can start interpreting them on your own. But, you know, as for then changing management, you'd want to get there a bit more slowly. Yeah.
I would say just to keep practicing and be really, it's a very humbling experience delving into ultrasound. And the more you do, like most things, the better at it you'll get, the better you feel. Don't ever be afraid to ask questions. As you probably see in all of these meetings, we're all still learning and learning from each other. And so it's really exciting, and we should kind of all keep having that training mentality as we go through this.
Great. Thank you so much. And, you know, thanks to all of you for being here, for sharing your experiences and engaging in discussion. And I think we can wrap up for today. Unless there's anything anybody else wants to share at this point. I will share also a screen for a second. Give me a moment. So Laura just put it in the chat, or you can use the QR code here to fill out the evaluation for this session, and you know, let us know your ideas for future, and you know, how we can make this as good of a session for all of us as possible. But thank you for joining, and thanks to Daniel and to all of our panelists for really leading us in a great session today.
Thank you.
Thank you all.
Thank you.
Bye.